Okay, so this will be part two of the acute mesenteric ischemia discussion. And one thing I want to go back to just for a few moments before we move on to the other types of acute mesenteric ischemia is with the SMA embolization. Again, we emphasize the most common etiology as some cardiac source. So a mural thrombus, most commonly from atrial fibrillation, or in other instances valvular vegetations, can originate in the heart, embolize out to the periphery, and in this instance the intestinal tract and specifically the superior mesenteric artery, and cause ischemia there. Additionally, you can have arterioarterial emboli, either from abdominal aortic aneurysms and the plaques and things which are in the wall of that, or other plaques along the arterial route proximally anywhere, can embolize distally, particularly if manipulated by catheters. Now, one important point, and I actually just did a case yesterday, I think that emphasizes this, is that when you see truly segmental and limited small bowel ischemia, that can be from a cardiac source, but it's more commonly from an arterial source. You see, in this case, this gentleman has a significant amount of superior mesenteric artery plaquing. Actually gave us concern he might have a superior mesenteric artery thrombosis, which we're getting ready to discuss in a few moments. But in actuality, it appears that he probably broke off a plaque from one of these and lodged distally, and we simply had to do a small bowel resection. This area here, which may have just been a diverticuli, worried me a little bit too, so we did end up taking the cecum out as well. This is on the cecum out of concern. This could possibly represent evolving ischemia, but I think clearly here you see the well demarcated, very segmental segment of small bowel, and this will probably be proven to be from an arterial embolus, either from the aorta or from this SMA disease. Now, we are going to have him worked up from a cardiac standpoint as well, get an echo, etc., to make sure that it wasn't just a very small clot which came out, because that's also possible. Okay, let's move on now and talk about the other causes or the other etiologies of acute mesenteric ischemia. The second most common is superior mesenteric artery thrombosis, accounting for approximately 30% of cases. And the mechanism here is you have an acute thrombosis of a pre-existing plaque during typically a low flow state, or like happens with myocardial infarctions, often with intraplaque hemorrhage. The clue to this will often be that the patient will have some evidence of chronic mesenteric ischemia going into this. Not always, but in many instances, the postprandial pain, the so-called food fear, where they're afraid to eat because of the pain that they tend to get after eating, kind of a angina of the bowel, or intestinal angina as it's sometimes called, and significant weight loss as a result of this. So these should be historic findings that should heighten your suspicion that this may be an SMA thrombosis that you're dealing with, rather than an embolus if the patient has some findings suggestive both on history of chronic mesenteric ischemia predisposing this. Now, SMA thrombosis is worse in that you don't have this area of small bowel sparing here, because basically it's the entire SMA that's out. You don't have those few jejunals and the middle colic being spared. So the colon is more often more involved over toward the splenic flexure, and so you don't have really as much, at least if at all, transverse colon sparing, and you really have minimal small bowel sparing. Duodenum or proximal duodenum may be all that is viable. So bad player when it occurs. Here you can see a CT recon. You can see the celiac axis is okay here, but a very tight SMA thrombosis here. So this is more difficult in that you're not going to be able to get by just with a thrombectomy and plus or minus bowel resection. You're going to have to do some type of bypass. And here they talk about doing longitudinal rather than transverse arteriotomies to facilitate a true subsequent bypass graft. They mention that the lie, if you will, of the bypass is better if you go supraceliac, or if you go above the celiac aorta and tunnel the graft or move the graft down. However, that's a very difficult exposure is the downside of that. Retrograde, easier exposure, but you tend to have more kinking of your grafts and stuff. And you can see here in some instances, a vascular surgeon will elect to bypass both the celiac and the superior mesenteric artery. A lot of surgery involved with that, though. So there are other treatments as well. Endovascularly, these can be approached. Now, sometimes you're going to still have to do a bowel resection, obviously, But, I think there is a role, obviously not for the patient that has an acute abdomen, not for a patient that has evolving sepsis. Those patients need to go to the OR expeditiously, get the infarcted bowel removed, save as much bowel as possible, though, and then you turn your attention to the revascularization, which is usually done operatively. However, that can be a very difficult exposure, especially if the patient has had previous manipulation of the area. Many of these patients will have had previous aortobifims. Many of them will have aneurysmal disease, so it's not just an easy thing to go up there and put a bypass graft in. So there is definitely a role, an evolving role for endovascular treatment, certainly for chronic mesenteric ischemia, but I would also argue for acute exacerbations of chronic mesenteric ischemia due to SMA thrombosis in certain settings where lytics and stenting can be very helpful. Certainly this does not address, though, once again, the bowel viability, and you still often need to do surgical intervention to address that. But if the patient is not presenting with an acute abdomen, if they're not developing sepsis, if they just have pain and you think it's early on, I don't think it's at all unreasonable to involve your vascular surgery and or your interventional radiology colleague, get a formal angiogram and see if that is perhaps amenable to stenting. You can still go in after that and take the bowel out if take the appropriate amount of bowel out if that situation evolves, but then you've already addressed the vascular insufficiency issue in a less invasive and I think perhaps in at least our elderly patients less morbid fashion. Certainly this is best suited for chronic or partial occlusions. Complete occlusions obviously are hard to get a wire across. Here's a case that I think worked out well for us. This was a 65-year-old male who presented with a 2-day history of abdominal pain, and this specifically was really an exacerbation of a postprandial pain which had been occurring intermittently for the prior 3 months. He had lost about 20 pounds during this time. The pain was periumbilical in nature, as would suggest a midgut issue. It was constant, and at the time of presentation, it was an 8 out of 10, so pretty severe pain. Past medical history, what you would expect for a vasculopath: type 2 diabetes, hypertension, history of coronary artery disease for which he had been stented in the past. He had had a TIA in the past, and he did have documented peripheral vascular disease. Past surgical history: aortobifim, so big deal. That area's been instrumented, at least distally. He's had a carotid endarterectomy. He's had a left femoral embolectomy, so all evidence of significant atherosclerotic disease. Certainly he also had an open cholecystectomy. So again, this would be a patient not all that easy from an abdominal exposure standpoint, most likely, given the previous surgical interventions. And that was, by the way, an open aortobifim, just to clarify. Outpatient medications: metformin, insulin. He's on Plavix, lisinopril, Prilosec, and the other medications you see there. Unfortunately, continued to be a 2-pack per day smoker, which certainly was not helping him any. He was not in acute distress on presentation, other than his abdominal pain, but when he was lying still and after he gotten a little bit of pain medication, when we saw him, he wasn't in acute distress anymore, and his pain had improved somewhat, again with analgesia. His temperature was 90, he was afebrile, I should say. Pulse was 99, respiratory rate 16. He was actually hypertensive, respiratory rate, I mentioned twice there for good effort, I guess, 16. His weight was 135, which gave him a BMI of 22. His abdomen was soft, mildly tender, and distended, but no guarding or rebound tenderness, so no peritoneal signs on examination. Extremities: he had 1 out of 2 pulses. They were warm. His white blood cell count was moderately elevated at 14,500. Electrolytes were normal, and there was no evidence of acidosis on his basic metabolic panel. He did undergo a CT scan in the emergency department, and that did demonstrate a very limited amount of portal venous gas. You can see the slight amount of gas out here peripherally. You can see the evidence of significant atherosclerotic disease here in the aorta, and particularly at the takeoff of both the celiac and the SMA, there was severe plaquing here, which you can see on this non-contrast scan. So certainly a patient that's at risk for significant superior mesenteric artery thrombosis issues due to an exacerbation of his underlying atherosclerotic disease there. He did have, although he didn't have any free air and he didn't have any ascites, he did have some, and he did not have mesenteric venous gas. We could see he did have evidence of this linear pneumatosis. You can see here maybe some of the bubbly type pneumatosis here. So pneumatosis intestinalis was present as well. So at this point, summing this patient up, I felt that we had a stable patient. He had abdominal pain, but his abdominal examination was not an acute abdomen. So I felt that this was a patient, particularly given his previous operative intervention in the retroperitoneum, would be best suited potentially by an endovascular approach. So we got him started on some IV fluids, we got him on antibiotics, and we quickly involved our vascular surgery colleagues. Dr. Kowicki managed this case to obtain a formal angiogram and, if appropriate, stenting. And I felt like probably we'd still need to take the guy to the operating room after that, just given, his significant pain and the white count elevation. But again, I didn't think our hand was being forced to do it emergently right now. I felt that we could resuscitate him in accordance with surviving sepsis guidelines, good fluid resuscitation, early and appropriate broad-spectrum antibiotics, get some more information, and maybe at least do the revascularization from an endovascular approach. Dr. Kowicki did indeed find, as expected, significant narrowing of both the celiac and the superior mesenteric artery axis. The SMA axis in particular was problematic. He was, however, able to measure out these links and did feel that this was amenable to stenting, and was able to get nice stents across both the celiac axis and the SMA axis. The patient did subsequently actually return with some recurrent abdominal pain, and we were able to get a CT scan. A CTA subsequently was performed, which showed these were open, and this just kind of gives you an idea how they look on the reconstructions from the CT scan. But here you can see on the completion angiogram, very nice placement of these stents. And the patient actually got better. His white count normalized fairly promptly. His abdominal pain resolved. We let him eat, and he did fine. So this patient did not have to even undergo operative exploration. And he was discharged home 3 days after presentation. He did come back in a couple weeks later. I thought he was going to have a stricture or something, but yeah, I don't know what it was, just a viral thing or something. He was in and out in 24 hours after a negative workup at that point. So I think a pretty successful story here for a case of evolving SMA thrombosis or exacerbation of chronic mesenteric ischemia with acute component, which was able to be managed endovascularly. Certainly not all are able to be managed in that fashion, and you can't hesitate to take them to the operating room, certainly if they develop peritoneal signs, if they develop worsening abdominal pain on therapy, or if they fail otherwise to respond to therapy. But I think that at times, perhaps at least the revascularization may be best done in a non-surgical fashion. Now, in a younger patient, problem with these stents are we don't know the long-term durability of these. Most likely they do not stay patent as long as a good bypass graft will. So, in a younger patient that has more life ahead of them potentially, or in a patient that, and particularly in a patient that has not had previous operative intervention to the retroperitoneum, then it may be more appropriate to consider operative intervention up front. Non-occlusive mesenteric ischemia accounts for about 10 to 15% of cases. This is basically where you get a splanchnic vasoconstriction. So these are patients that are in extremis, often due to other non-bowel related issues. Hypovolemic shock due to sepsis, due to cardiogenic etiology. Patients have had CABGs with complications. Patients are on high-dose vasoconstrictors. Digoxin also increases the risk of it. Dialysis patients. So anything basically which is causing a significant sympathetic redistribution of flow can result in a non-occlusive mesenteric ischemia. High mortality, likely related to the underlying problems causing it. Of note, just for kind of numbers' sake to have in your head, your normal splanchnic blood flow is about 10% of cardiac output. After you eat a big meal, you need that to go up to about 35% of cardiac output. And in some instances, if you've got significant plaque disease, for example, at the takeoff of the SMA, your bowel is not able to do that, and so you get intestinal angina. In cases where you have non-occlusive mesenteric ischemia, the problem is a little bit different. It's just that everything is clamped down so tightly that you're getting the same effect. You can't get the appropriate perfusion to the bowel. This is a diagnosis that, I say angiography, it's definitively made angiographically. I'll be honest with you, in this day and age, I don't get angios all that commonly in these people. I just treat them aggressively, make sure they're being as far as with resuscitation, not surgically aggressively, but make sure that the resuscitation is being appropriately aggressive. And in most instances, they're either going to get better from their systemic issue or they're not. And we usually just kind of follow along. In some selected instances where I feel like they may have a greater chance of getting better, it may be reasonable to get an angiogram. You'll typically see kind of a pruned branch appearance here where you see the smaller vessels are not lighting up because they're all clamped down. So-called string of sausages sign, where you have multiple sites of kind of vasoconstriction, may also be noted. And if you're in there doing an angio, you can sometimes benefit these patients with installation of intra-arterial papaverin, which, by the way, has also been shown to be helpful after you do your thrombectomy for SMA embolic cases. And I probably should have mentioned that introduction of intra-arterial papaverin helps to reduce the vasospasm there, as it does here in this case of non-occlusive mesenteric ischemia. So in some instances, we'll have the interventional radiologist or the vascular surgeon leave the catheter in place, leave the papaverin running, and then recheck, after a while, and then, consider getting the catheter out whenever the patient's not at risk for significant bleeding from it. But sometimes continue this even for a day or so. Sorry, I got interrupted there, but papaverin is sometimes used here. Now, you got to be careful, though. It can cause hypotension, which obviously isn't good in these patients. You also can't run it concurrently with heparin. Anticoagulation is not typically beneficial in this disease process anyway, but more often than not, just ongoing appropriate resuscitation, and the patient's either going to get better from their systemic issue or they're not. Here is a striking example of the prune tree appearance being improved with post-papaverin on post-papaverin angio. Mesenteric venous thrombosis. These patients have the best prognosis, although are often some of the hardest to diagnose if you're not suspecting it. 5 to 10% of cases of acute mesenteric ischemia are accounted for by mesenteric venous thrombosis. You can see here the mortality is much lower than other causes, somewhere in the range of 20 to 50%, depending upon the series. The most common patient you see this with is young females on hormonal, not necessarily hormonal, but birth control pills. So birth control pills and young to middle-aged females seems to be one of the most common inciting causes of this. In other instances, there's a traumatic component that kind of revs up the coagulation cascade, or some type of a static issue where you have a stasis in the venous side, or hypercoagulable states such as protein CNS deficiency, etc. And again, you see here oral contraceptive use here. So think about some type of hypercoagulable state in these patients, or some type of condition causing stasis. Approximately 50% of these patients will be patients that have demonstrated a prior propensity to clotting by having a DVT or even a PE. CT is pretty good for this, not necessarily always directly seeing it in the vasculature, but certainly the bowel changes that you see. But even sometimes you can see a central lucency or enlargement of the superior mesenteric vein. But more commonly, what you'll see is the secondary issues of bowel wall thickening. We used to see it on venous phase angio. That's less commonly done now. Mesenteric duplex can sometimes pick this up as well. And by the way, the role of duplex evaluation in the setting of mesenteric ischemia, it's probably the initial test you should do, particularly in a thin patient that is at risk for chronic mesenteric ischemia. If you have a patient you think has chronic mesenteric ischemia, it's less helpful in the acute setting, but can sometimes be helpful, particularly in a thinner patient. If their abdomen is very tender, though, and they have peritoneal signs, obviously that patient needs to be probably in the OR, and they're probably not going to tolerate a duplex study very well. But mesenteric duplex can sometimes make the diagnosis for you. But in this day and age, the vast majority of the time, we make the diagnosis on a contrast-enhanced CT, which carries a 90% sensitivity. overall when you account for the bowel changes that you see. Venous phase angio, it's hard to see here, but you can kind of see the mesenteric vein coming back here, and then it's kind of cut off up here. Treatment for mesenteric venous thrombosis is anticoagulation, and as long as they don't have peritoneal signs or sepsis, then you don't necessarily have to go to the operating room with these patients. But indications for OR, certainly peritoneal signs, so an acute abdomen, sepsis, which doesn't respond very quickly to non-surgical intervention, including anticoagulation, antibiotics, and fluid resuscitation. The presence of significant thickened bowel or ascites, particularly with an obvious clot seen on CT scan. And this, kind of like arterial emboli, tends to cause segmental infarction. Here's a case study, a patient I dealt with a number of years ago now, 34-year-old white female with no history of medical problems, but was on oral birth control pills, came in with complaints of approximately 12 hours of periumbilical abdominal pain and nausea. She also had on examination tenderness with guarding in the right lower quadrant and the periumbilical region. She did have a significant leukocytosis. CT scan did demonstrate the presence of a clot in the portal and superior mesenteric vein complex. As you can see here as well, there was secondary small bowel inflammation. The patient was treated with IV hydration and antibiotics. We minimized her analgesics. She was placed on a heparin drip, and she was followed very closely. She did gradually improve. Sorry again for the interruption, but the patient gradually improved. Again, we were watching her very closely, serial abdominal examinations, making sure that she didn't worsen, in which case we would have taken her to the OR expeditiously. But she didn't. She got better. Her hypercoagulable workup, which was performed with the oversight of hematology, was negative. Her birth control pills were stopped, and she was maintained on a different form of birth control. She was transitioned to Coumadin after being on heparin initially. She did well for approximately 3 weeks. Saw her back in the office, thought she was doing great, actually released her to the care of her primary care physician. But then she developed a recurrence of nausea, vomiting, and periumbilical pain. As she came in, her abdomen was significantly distended. Her white count was minimally elevated at this time. She had normal vital signs. CT scan showed dilated bowel, but no ongoing obvious mesenteric venous thrombosis or portal venous thrombosis. A small bowel follow-through was obtained, though, which did reveal significant stricturing in the small bowel. So basically, at least a portion of the ischemic area strictured down. We did subsequently take her to the operating room, confirmed the diagnosis of small bowel stricture, and she underwent an uncomplicated small bowel resection. She has since been maintained on Coumadin with no further problems. Question is, do you continue the Coumadin lifelong? I think that's a difficult question, given the potential morbid and even mortality associated. Given the potential morbidity and mortality associated with this, I would say probably yes. But I don't know that there's a hard or fast answer, and I think you have to apply it to each patient based on the other risks of anticoagulation, the other issues that they have. Let's talk about some associated topics, some associated thrombotic topics, if you will. Portal vein thrombosis. Etiology seen here, things which give you stasis in the portal flow, so cirrhosis, hepatocellular carcinoma, and other hepatic tumors, obviously hypercoagulable states, extrinsic compression that you'll see sometimes from surrounding neoplasms, such as pancreatic cancers, once again, oral birth control pills. The presence of intra-abdominal infection, which can lead to the condition of pylophlebitis, can also lead to a portal vein thrombosis, which can sometimes be a septic issue. Diagnosis, once again, usually made on CT, although Doppler evaluation and MRI can sometimes be helpful. Venous phase angiography was more of a mainstay in the past and not so often utilized now. These patients do require anticoagulation. If there's a septic component, such as an underlying infectious cause, then antibiotics, and obviously address any underlying cause. It can lead, if untreated, to portal hypertension and most concerningly to mesenteric ischemia. So patients with portal vein thrombosis do need anticoagulated. They do need a hypercoagulable workup. On the other end of the liver, the hepatic veins, thrombosis there goes by the nomenclature of Budd-Chiari syndrome. Once again, mostly the same etiologies: hypercoagulable states, pregnancy, oral birth control pills. Myeloproliferative disorders are particularly common in Budd-Chiari syndrome. Up to a quarter of patients will have a myeloproliferative disorder, most commonly polycythemia vera. Malignancies also certainly increase the risk, particularly hepatocellular carcinoma, which, due to being a cancer and releasing, all of the bad things that cancers can release, increases your risk of thrombosis, but also just due to pressure phenomena on the veins, you can see this. And for similar reasons, adrenocortical tumors and renal cell tumors are particularly at risk for this as well. Patients with liver abscesses can, sometimes result in stasis of the hepatic veins, and you can get hepatic vein thrombosis in this as well. Once again, very commonly seen in young or middle-aged females, particularly those on birth control pills. 67% or two-thirds of patients that have this are female with a median age of 35. And these present with liver failure. 20% will present with fulminant liver failure that may require acute liver transplantation in order to avoid mortality. 40% present with a more subacute presentation. The most common manifestations of this in both instances being ascites and hepatomegaly. There's a chronic presentation which presents with the more long-term issues of liver failure, of cirrhosis and portal hypertension. Diagnosis very frequently made with Doppler here, a little bit tougher to make on CT scan or MR, although it can be done. And in some instances of the chronic conditions in particular, liver biopsy is necessary to make the diagnosis. The treatment here is usually angioplasty and lytic agents. TIPS also has a role depending upon how far along the issue is. Portosystemic shunts, surgically less commonly used, or liver transplantation, particularly in those patients that have gone on to cirrhosis. Okay, last topic is colonic ischemia, and this is something that we see fairly frequently. This is actually the most common form of intestinal ischemia, and essentially what you're dealing with is ischemia in the inferior mesenteric artery distribution, which tends to have a much more benign course and is less commonly due to a true thromboembolic issue. It's more commonly just due to a low flow state and is more responsive to medical management. You see a wide spectrum, though. These patients can present with frank gangrene and can require emergent surgical intervention. More commonly, though, it's more of a transient colitis. However, that can sometimes lead into a chronic colitis with stricturing. And so it's not infrequent that we have to operate on these patients, but the initial therapy is certainly non-operative. As you can see here, the descending colon is one of the most common areas that this occurs, along with the splenic flexure. It's kind of those watershed areas. Most of these cases, you're not going to find a recognizable cause. You do have to worry about, is there a low flow state due to cardiac issues or due to some medications you have the patient on? Is the patient becoming dehydrated? Long distance runners, probably related to dehydration, have issues with this. Cocaine, because of the vasospastic issues, can increase your risk of this. Elderly patients that are prone to some of these other issues are at increased risk. They typically present with abdominal pain, either suprapubic or periumbilical, and diarrhea. They may have kind of a low caliber GI bleed along with this. The diagnosis will often be made on CT scan, where you'll see inflammation around the splenic flexure or around the left colon or the sigmoid colon. Colonoscopy is helpful in confirming it, where you'll see these ischemic changes, hopefully usually non-transmural. Angio can occasionally be helpful, but is not all that common. But worry if you see right-sided involvement. Now, right-sided colonic ischemia ought to get your attention, because that's going to be more often, a true case of acute mesenteric ischemia. Left-sided is more often, the non-operatively favored colonic ischemia. Treatment is bowel rest, IV fluids, and antibiotics, and you can survey them with colonoscopy. This is a patient that's probably going to go on and need surgery sooner rather than later. This is a patient that's probably going to be okay with non-operative management. What are the indications for taking these patients to the operating room? Obviously, development of an acute abdomen, if the bleeding is significant or persistent, or fulminant colitis. Subacute indications are if these patients just fail to get better, you continue just to have this protein-losing enteropathy or colopathy where the patient is becoming significantly malnourished, or they just have ongoing bleeding, or they just keep bouncing back. Those are, in some instances, an indication. The problem is many times these patients are very, very ill and very high risk, just on a chronic basis, and are high-risk surgical candidates. And again, the more chronic indications, stricture, or persistently symptomatic segmental ischemic colitis. Okay, so that is it for mesenteric ischemia. Hopefully this has been helpful, and certainly we'll also look for input from our vascular surgery colleagues, as they're very integral in our management of a number of these cases. Thank you.